I don't like the way my head is looking in the light. Yeah.
Dr. Kiarie, we are ready to start. Thank you.
So thank you very much, everybody who has joined tonight's session, which is convened by the Kenya Society of Hematologists and Oncologists as part of our clinical education. And we also meet our advocacy mandate in this meeting. We bring together clinicians, policymakers to support open, evidence-based conversations on cancer care in Kenya. And our session tonight is on commemoration of the World Cancer Day that was commemorated yesterday, 4th of February. And the theme of the next 3 years, 2026, is United by Unique. KESHO's role in this CME is to convene stakeholders and also try to elevate patient needs, help advance practical collaborative solutions that improve outcomes for people affected by cancer. Now tonight, we also will have members of the Fourth Estate, the press are present, who will have an opportunity to pose questions to the panelists that we have. I'm very delighted to have people who are hands on deck, who are very key stakeholders in the oncology space. Now, behind every cancer diagnosis, there is a unique human story about pain, healing, resilience, and love. Cancer in Kenya is as unique as it is similar to other countries in the region and internationally. The numbers of the newly diagnosed patients now stand at approximately 50,000 new patients per year. Unfortunately, close to 50% of those patients will die, sometimes in the first year of their diagnosis. There are more women than men who get diagnosed with cancer in Kenya, and there is a multitude of problems based on access, financial issues, lack of geographical access to treating centers, and of course, a lot of traditional issues as well as stigma, which cause retrogression in the treatment of the cancer patient. Having said that, there is great hope. In the last decade, we've seen an increase in access to diagnostics and treatment, and with the managed equipment service of 2015, we got equipping of many county hospitals, which led to increased diagnosis of cancer because imaging and biopsies could be done. In Kenya, we have access to newer drugs, immunotherapy, targeted drugs, stereotactic radiation, and to name a few, and we get regional referrals because of this access. Now, as we discussed this evening, care must be kept continuous, coordinated, and compassionate. And therefore, I feel delighted in welcoming our panel. And I'll start my introductions with Honorable James Nyikal, who is a member of parliament of the Seme constituency and currently serves as the chairperson of the Departmental Committee on Health in the National Assembly of Kenya. He is a pediatrician, and many of us went through his hands in various capacities as a newborn specialist, and he brings decades of leadership in Kenya's health sector, serving previously as a director of medical services, the permanent secretary in the Ministry of Health and Gender, and as a member of the World Health Organization Executive Board. In Parliament, he provides strategic oversight on health legislation, financing, governance, and implementation of the universal health coverage reforms. We do appreciate his unique combinations of clinical expertise, senior public service experience, and legislative leadership, which makes him a leading voice in shaping evidence-based health policy in Kenya. Karibu sana mheshimiwa. Then we have Dr. Ouma Oluga, who is the Principal Secretary in the State Department of Medical Services in the Ministry of Health in Kenya. He is a leading healthcare technocrat and consults on offering thought leadership in our health systems, designing expertise in specialized health context analysis services to the government, to many policymakers, organizations, investors, and professionals who seek to partner and engage with Kenya in creation of some of these programs and practices. We do look forward to the engaging discussion we shall have with him. Dr. Oluga is a certified physician. He's a consultant physician and also a labor license designated health practitioner. And he is also has a fellowship in health monitoring and evaluation and a postgraduate diploma in infectious disease. Karibu sana, Dr. Oluga. Now, I'm also very privileged to invite the third panelist, who is Dr. Ahmed Ogwell. He's a Kenyan public health expert with experience spanning 3 decades in national, regional, and global levels. He's most recently the Vice President for Global Health Strategy at the UN Foundation, where he spearheaded global health policy, advocacy, convening thought leadership, and grant making in support of the UN's priorities. He's also been a Deputy Director General at African CDC, an institution he served in various leadership capacities, including acting CEO and the founding Deputy Director. As he led Africa CDC, there was a time of significant growth and transformation, and he steered Africa's complex and successful response to COVID-19 pandemic, as well as other threats like Ebola, Marburg, and cholera. So we welcome Daktari to this discussion and benefit from his wealth of experience. I'll then introduce somebody who is very difficult to discussion, and that is Dr. Diana Marion. Dr. Diana Marion is the director in the Social Health Authority, Provider and Beneficiaries Management Directorate. She's a senior health executive and also a global health leader. Dr. Marion is a consultant obstetrician and gynecologist who has worked in various capacities, including a deputy director of medical services, a senior medical specialist in Nyanyuki Teaching and Referral Hospital, and she's also has some advocacy roles under her belt. She's a passionate health system strategist, and this evening we shall be talking to Dr. Marion about the role of Social Health Authority in providing care to the oncology patients. And last but definitely not least is Prisca Githuka. Prisca is a lived experience advocate who champions voices in Kenya and across the globe, ensuring that advocacy, policy, and health systems reflect the realities of those most affected. She leverages on her experience as a patient to raise awareness on that and gynecological cancers, as well as promoting prevention and support for survivors to live with dignity. She is a trained cancer advocate, a fellow of both the UICC Cancer Advocate Program and the Campaign for Cancer Patient Advocates Incubator Program. She also chairs the Cancer Survivors Association of Kenya and is the vice chair of the Kenya Network of Cancer Organizations, otherwise known as KENCO. In her other life, Prisca worked in KCB in the foundation and therefore is very well placed to be involved in some of our discussions this evening. So I welcome you all for accepting our invitation to have this very important dialogue this evening, seeking deliverance of proper service to the Kenyan patient. Now, if you allow me, I'll start with Dr. James Nyikal, who is the chair of the Parliamentary Health Committee. Daktari, from the legislative and oversight perspective, what priority actions does Parliament focus in strengthening health financing? Is it pouring more money? In allowing cancer prevention strategies to be carried out? And in this special reference, you being a pediatrician, to the cervical cancer vaccine. It was rolled out, but there was very poor uptake, as well as creating equitable access to oncology services in Kenya. Daktari, I'll add to that, talking about the actions of Parliament, to the Kenyatta University Teaching Referral Hospital, which received a 3 billion bailout by Parliament, and it holds the great strategy of providing multidisciplinary care, not only in oncology, to Kenyans, and the problems that it's facing today, lack of even blood transfusion facilities for patients. What is Parliament and yourself as a chair of Parliament doing about that? Asante sana, Daktari. Dr. Nyikal? I think you're on silent, you're muted. Daktari, we can't hear you. I don't know, Maureen, we can assist Daktari so that he can be able to answer the question. I don't know whether as we assist him, I can move to Dr. Oluga. So Dr. Oluga, as Honorable Nyikal is trying to get himself unmuted, I have a question for you. Appreciating the great help that you've been to the Ministry of Health in your very good understanding, having gone through training through the system, and also being an advocate of change when you are a leader in the Doctors' Union. So Daktari, from a service delivery perspective, how is the Ministry of Health strengthening oncology and hematology services across all levels of care, including referral pathways, infrastructure, and workforce capacity to improve patient outcomes? Maybe we can just begin with that. Thank you, Daktari.
Thank you. First and foremost is to appreciate this invite by KESHO to participate in this World Cancer Day commemoration, which is driven by the theme United by Unique. Now, we have a number of initiatives within the ministry. And of course, you know, first and foremost, we have to talk about the overall goal of government. The overall goal of government is to preserve and protect lives and livelihoods, and then to ensure that the populations are not only healthy, but they're also productive and thriving. And I think this is the nature of all. This is the nature of all governments all over the world. And it comes in several facets, not just in health, but of course, health is an underpinning pillar in ensuring that populations are productive and that populations are also thriving. And so from a Ministry of Health perspective, the biggest goal is on policy and also on the standards. And service delivery, of course, comes because the Ministry of Health has a role in the management of the national referral hospitals as per Schedule 4 of the Constitution. Ideally, what is key for the Ministry of Health is to set an environment that enables provision of services, including investment for services. But of course, as you know, in our setup, because of the unique nature of healthcare investments, and also because of the unique nature of the costs that are involved, we are still in a phase where government has to directly invest in the provision of care. And that is why your question around service delivery is key. And so looking at service delivery specifically, two things that are important for us. Number one is that we improve the experiences of patients. And number two is that we improve the outcomes of patients, particularly in cancer care. And so when we talk about the experiences of patients, it's basically navigating the healthcare system. And navigating the healthcare system relates to three key issues. Number one is information. Number two is access. But number three is also the design of the processes that then enables easy flow of one process to another. Now, from where we sit, the experience of patients has become a key target in terms of what we want to achieve. And on that, we have been keen to engage with healthcare workers to ensure that we are treating healthcare workers very well. We are investing in, a well-being of healthcare workers. As you note, I think this is the first time in a long time where there's a lot of quietness in the health space, trying to fulfill all the obligations from a contractual or an employment perspective of health workers, but also improving their competence through training programs. We are also engaging with many institutions, particularly healthcare institutions, to design work properly so that the person who is giving care is well enabled and well positioned in terms of mindset to also deliver that experience to the patient. But more importantly is also to arrange the healthcare system in such a way that patients can easily access, but also can easily navigate in terms of move from one point to another. And we have just reaffirmed the issues around service charters, because one of the biggest challenges that we noted in our quality of care report that we did and launched last year is that most of the cancer patients take at minimum 5 months before diagnosis. And often we say that patients do not come to care early, but it is not true that they don't come to care early. What is true is that they go to a health center, they go to a dispensary, they go to a private clinic somewhere, but the high index of suspicion is not there. The diagnostic tools are not there. The trust in the healthcare system is somewhat lowered, and therefore the patient may get treated, because cancer also presents just like any other disease, presents like headache, it presents like pain, it presents like anything else. And so patients have a lot of repeated interactions with the healthcare system before there is a diagnosis. So that already is bad patient experience. But for us as government, it's not just bad patient experience, it's also higher costs. So most of the patients, by the time they are getting to be diagnosed, they have almost depleted all their money. And sometimes they have even depleted their cover if they are insured, whether privately or insured socially through the social health insurance. And these are key things for us when it comes to experiences, because then they start to worry about the finances rather than about the care. And this is also a big burden socially for families who are taking care of cancer loved ones. And now when it comes to the whole issue about outcomes, again, three things are important. Number one is that we do early detection and early diagnosis. And you mentioned, Dr. Kiarie, that previously the government invested quite a lot in terms of equipment. And right now we have the National Equipment Service Program, which is being rolled out to ensure that laboratories are available. But also we have rolled out more than 84 mammograms, for example, for early detection and screening for breast cancer. Again, we have engaged in a number of equipment support to ensure that the uptime is good. But then beyond that also is the care, and just investing in the care to make sure that our 6 cancer centers in the public sector, but also there are a number of cancer centers in the private sector, are properly supported to be able to provide proper care. There is a bit of progress. If you look at the number of patients, for example, who die per year, there's been a bit of a decline, despite the fact that the number of diagnoses are increasing. We are not yet there. We still have to do quite a lot to improve outcomes for cancer patients. But these are key things for us. And I know when you look at the cancer control policies, these are things that come up. And so I will stop here. But of course, overall, I know the architecture of the healthcare system is important to talk about, and health financing is key to both the experiences and the outcomes. And that's why the Social Health Authority is the basket through which we put in all the money. And that is why cancer, being a diagnosis that can either make you extremely poor or can make you die, we are keen to ensure that we cushion it financially. And then, of course, all the other things about health workforce capacity and competence, the issue around the availability of products, and particularly the uniqueness of therapies. Right now, you've mentioned the immunotherapies, the biologics, and how cancer is precisely being targeted. And lastly, of course, the digitization that we are pursuing to ensure that our systems are unified and that we have single sources of truth, so that our decisions moving forward for cancer patients can be as precise and as unique as the patients that come through. And so I'll stop there, but we are also keen to support institutions like KESHO and all the other cancer institutions to facilitate a proper environment where cancer care can be given to patients for better experiences and for better outcomes. Thank you.
Sorry, very well said about, the service starters, the quality of care reports, and the higher costs when patients are over-investigated before a diagnosis is made. All we can say, Daktari, is that through our society, we shall create synergies and align some of these algorithms of care so that we have very specific investigations and specific timelines to be able to sort of make this uniform for patients. In other countries, there is a 2-week period in which somebody should have a confirmed diagnosis of cancer and actually stage. So I do thank you for those comments and hope that they'll come to fruition. Through our interactions also with SHA, we shall be talking about soon, issuance of protocols which should be followed. I think with those few remarks, we can check if Honorable Dr. Nyikal is ready probably to respond to the first question. Daktari, maybe if Dr. Nyikal is finding difficulty to get back on, would you like to comment about the cervical cancer vaccine uptake? It was a Ministry of Health initiative, very well thought, probably poor uptake, maybe because of marketing and probably some of the problems we have with traditional religious factors in the uptake. Maybe you just can comment if we're going to have that running again.
Thank you so much again for that. In terms of cervical cancer vaccine uptake, well, we don't view it as poor uptake. We just view it that it's progress. I think right now we are at 30% uptake, which it isn't bad depending on how you look at it and where we are coming from. Of course, our target is to get to 90% of our children between the ages of 9 and 15 years. And that's one of the areas where we want to collaborate with all stakeholders to get the information out there to reduce any misgivings about vaccination, but also to increase access, because the issue about vaccine uptake is also about access. And what we have done this year, and you've seen that across all our vaccination programs, we've had more than 62% in terms of financing, and that is just by half the year. Again, the first year that we are keen to ensure that there is no noise as far as vaccine availability is concerned. And so I think there's still quite a lot of work to be done there as a shared responsibility between ourselves as government, but also with experts like yourselves, because you see patients every day. You belong to a community, you belong to a village. I know that there is still a gap as far as policy is concerned on the whole issue about sex education in schools, and this target group, there's still some barriers that we still have to overcome, which is not just policy issues, but also, as you mentioned, is context issues with our society. And we are working across that to ensure that the vaccination for cervical cancer is targeted, but also reaches the threshold that we require, which is 90% of these age groups.
Wonderful, Daktari. And I think the commitment you can get from societies like us is actually to help in some of that deliverance through our outreach programs. Now, as we wait for Honorable Nyikal probably to get back online, I want to extend a question to Dr. Diana Marion. And my question is about the SHA model, or the Social Health Authority model of cancer financing. How does that model differ from the former National Health Financing, NHIF, oncology cover in real terms? How is that different? Is it in amounts? Is it in the people they cover? Karibu, Daktari.
Thank you, Dr. Gladwell. I want to appreciate SHA being invited to this meeting. I stand in on behalf of my CEO, Dr. Mwangangi, and I also want to appreciate that I have my bosses here, the PS, Dr. Ouma Oluga, and the chair of the health committee, Dr. Nyikal, and my colleague, Prisca, and also Gladwell, you're my colleague. So I want to start from the broader perspective. So what I would like us all to understand is that NHIF laid the foundation. And when policies are put in place, we don't say one was better or worse than the other. We say lessons are usually learned, and as lessons are learned, then policies are improved based on the learnings we have. So what we have is that NHIF was there and it did some good work for Kenyans. But SHA picked that up and picked the learnings. What was here, what was not here, and therefore how do we get where we need to get? So what has the SHA done? SHA is strengthening and expanding the coverage, and this is in the spirit of UHC. What we want to achieve as a country is better access, is comprehensiveness. So you will realize that it's an agenda that is actually very well advised, and it's the model that has been utilized right now is the differentiated care model. And what does that mean? That we are now doing what we call priority management. We are also looking at how can we cover this patient comprehensively through the different funds. And you realize NHIF was one fund, but SHA has several funds where the resources are unique for a specific solution. So in primary healthcare fund, you will realize that for the primary healthcare services for cancer patients, you are able to access services through that. And you realize that at this point in time, then diagnosis can be made. You can have a specific test done at primary care level, and that is covered by SHA. Primary healthcare is fully funded by government. Then you have the comprehensive care that is covered under the SHIF. And in the SHIF, you must actually be a paid up member to benefit from that. Why? Because now this is that fund where we pull up resources so that we are able to sustain the comprehensiveness of care in this country. Then we look at the ECCIF, and again, you will realize that the cancer package also is covered under that fund, and that fund is again fully funded by government. Now, we have what we call the Oncology Benefit Service Charter. My boss, Dr. Oluga, mentioned it. And what has happened currently is that we have strengthened the oncology package, and this has been advised through data. Now, how do we use data? You realize that we have used the current integration to automated systems. And through this automated system, that is through the Digital Health Agency, we are able to have specific, clear data-driven information, and we are using this information to make improvements on the various packages that we have. So what have we noted in the cancer journey? That we currently have rising cost of diagnostics and medicines. We have high benefit exhaustion rates, and then we have now the burden of out-of-pocket. So that is what actually advised the current benefit service charter. And I would like maybe to just briefly run you through what it means. So I'll take you through the overall cancer journey. So you will look at the cancer diagnosis, staging, treatment, and follow-up. So it's all the way to aftercare treatment. Now, you will have 400,000 covering per person per year. And this person has to be SHIF registered. And we have over 140 cancer centers that have been contracted countrywide, majority of them being level 5s and level 6. We have a few level 4s and we have level 3s. Now, depending on the kind of service that a patient needs, then they will go to a particular level of care. Now, after your shift limit is exhausted, that's the 400,000. So what we had before from the ECCIF is the 150,000, and that has been enhanced to 400,000 upwards. So per patient per year, right now, based on the data analytics that we have done, we are covering up to 800,000. But does it end there? So from the primary healthcare fund, you will cover specific diagnostics. Then you'll also realize that the surgical package is covered also in your limits of the surgical care. So we have expanded that such that you will realize we are talking about chemotherapy administration. We will pay 5,500 per session. And usually the prescription will depend on the oncologist that is seeing this patient, and this is accessible in all cancer centers. Then you also realize one of the things that was not covered during the NHIF time, and I said I will not dwell on saying what and what didn't happen when, but I'll focus on the specialized cancer imaging services. We are talking about MRIs. We are talking about CT scans. We are talking about bone scans. We are talking about PET scans. So when we look at all that, then you realize that we have additional specialized imaging services that you can access in a household. And you can get these in the various imaging centers. Then we look at the treatment, and here we are talking about chemotherapy, hormonal therapy, immunotherapies. These are covered within the 800,000 annual limit per the MOH NCCP differentiated care model. Then the radiotherapy will cover 3,600 per session for radiotherapy, and you will get your sessions based on the prescriptions from your oncologist. Then for brachytherapy, we cover 40,000 per session. Again, the number of sessions we are covering is 2 sessions. Then we have 70,000 per session for SBRT. Then we have routine lab tests, and most of these you can get them in your primary care facilities, where we cover between 500 to 1,000 per test, depending on what the test is. Then we have the cancer-related surgery covered differently under the surgical package, and again, as prescribed by the doctor who is seeing you. Then do not forget we have the ICU critical care cover, where you are covered 28,000 per day up to 12 days. And we have supportive care medication, where we cover up to 10,000. So when we look at that specific cancer care charter, you realize we've made a lot of improvements in really reducing the burden for the patient. And maybe I'll just add a few more statistics. Since October 2024, when we rolled out SHA, we have actually treated over 43,561 patients in the over 140 SHA contracted facilities, and we have paid in excess of 7.5 billion in oncology claims. It's actually one of our big payouts. So I would maybe think at this point I've been able to answer that question. Back to you, Gladwell. Thank you.
Thank you, Daktari. So 43,561 patients treated under SHA and 7.5 billion spent in oncology alone is remarkable. I think all of us present can witness the fact that patient numbers in treatment facilities increased remarkably. Radiotherapy departments, chemotherapy departments, with the introduction of the co-pay sort of arrangement with government financing. I remember in Nairobi Hospital Radiotherapy Department, we used to radiate about 30 people per day when we relied on private health insurance and cash payment. and that completely increased to around 70 to 100 patients per day in this private facility, which is remarkable. And this didn't mean that the numbers reduced in the public facilities as well. Now, as government struggles to support the oncology patient, I want Prisca, who is a patient advocate, Prisca Githuka, to tell us through a lived experience how she feels about the government intervention that Dr. Oluga has talked about and what Dr. Diana has talked about, SHA-supported patient journey, and what aspects of care have made the greatest difference to you as, a cancer warrior, and also your interactions with many patients' experiences. What aspects have made a great difference to these patients, to you in particular, through your lived experience? Thank you. And Prisca, as you answer that, tell us which 2 priority areas you'd like to see most improved. What greatest experiences there's been for you and the people you represent, and the 2 priority areas that you'd like to see improved to enhance the experience of a cancer patient. Thank you and welcome.
Thank you so much, Dr. Kiarie. And I would like to also take this opportunity to appreciate KESHO for inviting me to be part of this panel, and also as I represent the Kenyan Network of Cancer Organizations, which is an umbrella body of cancer CSOs in this country. I'm a cancer survivor, and maybe I just take you a little bit back. Almost like 10 or so years ago, there was no oncology package under social health insurance. So it was you. If you're working, then you had your private insurance. If you're not working, it was you, your family, your job. So it was very difficult. Fast forward, a lot of advocacy work going on. We had NHIF introducing an oncology package, modest, but a good step, and we really appreciated. The oncology package in the beginning did not even cover diagnostics. Again, a lot of advocacy work, and then the diagnostics bit was introduced later on. Modest again, but much appreciated. Then fast forward again, we move into SHA, and now we have a comprehensive oncology package whereby we have the 400, like Dr. Diane has talked about, and we have the 150 under the ECCIF, so that makes it 550,000. But then we all know that the cost of cancer care is very, very high. So again, a lot of advocacy work, and we have done a lot of work as KENCO and other survivors. And again, we're able to agitate the government and to have that increased to 800,000 Kenya shillings. And I'll come back to that later. So what am I saying? We have seen a big leap from having no social insurance under the oncology package into having something with no diagnostics, into having something with diagnostics, and into having what it is that we have today, which is a good thing. Let's talk about in terms of diagnostics. So right now we have the diagnostics that are covered. Again, Dr. Diana, I'll repeat some of the things that you said. So we have the full blood counts, which needed to be done before even a patient goes through chemotherapy. Remember, this was not there before. So NHIF then was covering you for chemotherapy, but then again, you're struggling in terms of how do I get money for diagnostics? So most patients, again, abandon their treatment because they didn't have money for diagnostics, even though we had the chemotherapy and others being covered. Yeah, so this is being covered right now. Then we also have the issues of the drugs, like for example, the letrozole, they are covered, which is a good thing. This is a hormonal drugs that patients with estrogen and progesterone positive cancers are given, and they take these tablets every day for 10 years. Again, this is covered, which is also very good. We have something like the Herceptin. Again, I think Dr. Diana has talked about it or alluded to it. Again, back earlier on when there was no coverage, and then Herceptin was quite expensive. I personally benefited from Herceptin because I had triple positive breast cancer. And I can tell you at the time, Herceptin alone, I'm not even including any other costs, was 350,000 Kenya shillings. Where you get it? that is your problem. So today, when I look at what is happening, and there is this arrangement that the government has with Roche and Shah, and we have a patient going to Kenyatta, and they are able to get Herceptin at 33,000.
I think, Prisca, you can hear us? So she's giving the commendable story about Herceptin, which is one of the most valuable drugs in treatment of HER2 breast cancer. I hope we'll get her back quickly. And she was basically outlining some of the co-pay programs that have been started. I think as we wait for Prisca to come back, and her comments were so important, I hope she does, I'll just move on to Dr. Ahmed Ogwell Ouma, who is the CEO and president of Village Reach. Daktari, what is the role of multi-sectorial collaboration? That is, between government, NGOs, which you've been part of, and of course, our professional societies. What advice would you give us so that we can reduce the inequities in cancer? You remember the WHO or the World Cancer theme. The last one was close the gap. How can we be able to reduce those inequities in cancer outcomes? And can NGO effectively engage some of these payers, for example, SHA, maybe to contribute to their basket of funds that they have, and also probably influence policy and guidelines through the research probably they fund to create sustainable financing? I know it's a mouthful, Daktari, but this is what you do every day, and we appreciate you. Kindly give us some of your thoughts. Thank you.
Thanks, Gladwell, and a very good evening, good morning, wherever it is that we are joining from. It's a pleasure for Village Reach to be invited to this session today, and I appreciate that we are speaking a platform where we have hematology and oncologists. But I would like to step back to the community and tie that into your question around partnerships. The focus for cancer, that is, has for a long time been the clinical part of it and the costs that come with diagnosis and management. Yet, cancer starts from the communities and affects the communities whenever an individual is found to have any of those cancers. It's a very community affair, especially in the African context, in the Kenyan context. And we need to step back and ensure that when we are generating and allocating resources, it starts from the beginning, and that is at the community level before we graduated to specialized management. And I think looking at cancer at the management level before prevention and health promotion means that we don't get a holistic approach. Now, I see three big things here that we need to do, and that also speaks to the partnerships that we need to be developing. One is community engagement with the correct information. And I like this year's theme around uniqueness, because when we say cancer, it sounds like one thing, yet there are many cancers with very varied risk factors and geographical distribution. So that uniqueness needs to be worked into the way we engage with the communities for information, needs to be included in the way that we design messaging for the different communities and the different types of cancers, needs to be included in the way that we allocate resources when it comes to community engagement, the kind of information that we want to pass. And here, especially in the Kenyan context, community health promoters and cancer survivors are the pillars of that communication that needs to go out so that we know what to do to prevent. And we also need to appreciate the role of early diagnosis that can be able to save us from a lot of the challenges we face when it comes to late reporting. So that pillar is, for me, one very key thing where we have community health promoters being empowered to take to the community level basic information, and cancer survivors sharing their lived experience so that we know that this is a serious matter. This is one thing. The second is around how we deal with the whole area of diagnosis. And I want to say we need to move the diagnosis. We don't move the patient. What do I mean by moving the diagnosis and not the patient? Today, if someone is suspected to have one type of cancer or the other, that individual will have to move hundreds of kilometers sometimes so that they can be able to go and get things as basic as a biopsy. Yet, we have well-trained health personnel who could be able to do the required biopsy, and then that sample can then be the one to be transported to whichever laboratory will be required to do the diagnosis. That way we move the diagnosis, the sample, we don't move the patient. When the time for management comes, we can be able to see what options there are of treating, of managing whichever cancer that will be. So the second part for me is moving the diagnosis and not the patient, so that we get faster results, and it becomes less expensive for the individuals who may need that diagnosis. The third, and I think this is where a lot of effort has been made by the government. The third is, how do we ensure that the supply chain is in place for health products, and also what supply chain is in place for evidence to come from the community level. Supply chain for health products, for example, we've been talking about the HPV vaccine. Is it in place? Is it working? Will those who are interested in the far-flung parts of the country be able to access those vaccines in a timely manner after information has been provided? So that supply chain for health products, whether it is vaccines, it is medication, it is other consumables, need to be in place. And then the supply chain for the data, supply chain for the samples that come back to the center also need to be in place. And these three different levels require that we build coalitions and partnerships around it so that everybody is playing a role. For example, we have experts in, largely the bigger cities and towns of Kenya, but that expertise may be required in a smaller town, a smaller facility somewhere in the country. So instead of moving the patient, we could be able to use telemedicine to access those experts in a way that supports early diagnosis, that supports biopsying being done by a trained person, and supports whenever it is necessary, some initial management of someone who has been diagnosed with cancer. And utilizing technology, we can be able to reach more individuals, and that kind of partnerships needs to come where the experts, like those of you who are in KESHO, provide your expertise. The government provides the infrastructure. Advocacy is provided by those who have lived experience, and our community health promoters become an important source of data, information that is going to the communities and also that is being collected from the communities. So we all have a role. NGOs will always fill the gap where the government has identified a role for NGOs. NGOs will always fill a gap when there is need for expertise that may not be present in the whole chain of information and management for being run by the government. But we will not be able to do the deeper infrastructure development that is required for the easing of access that Kenyan students are facing in as far as cancer management is concerned. Let's not clinicalize it. We need to come to a level where we're engaging with the communities in a context that they understand, utilizing idioms and language that they also appreciate, and we get people to know that we can prevent it, we can avoid it, we can have early diagnosis, and not wait until the very last minute when things become very challenging. So that's the kind of partnership that I see, and it has worked in places. I'll give you one example. In Mozambique, we have an initiative we call Bate Papo, which in the local language means let's talk about health. And this is around vaccination. And HPV is one of those vaccines that has been very successfully deployed in rural areas in Mozambique because we have gone out, engaged with the communities, talked about the role of vaccines in different diseases, including cancer, introduced HPV, and then allowed the community themselves to be the ones who are actually spreading the word, engaging with their own neighbors to increase interest and uptake of those vaccines. This happens. It's been successfully deployed, and I think the Kenyan context where we already have community health promoters in place, it could be able to expand that reach in a very effective way. And Village Reach is always ready to be able to work with the government to ensure that that is being done in an organized way. Thank you. Back to you, Gladwell.
Thank you. Thank you very much, Dr. Ogwell. Very insightful points as you wait for Dr. Kiarie to rejoin us. Very exciting discussions. I think the cancer space is witnessing tremendous improvement, and we hope that this tempo is going to be sustained so that we can, impact on patient experience, as Dr. Oluga has alluded to. We can improve patient outcomes. We can engage with the community. I think, Dr. Ogwell, your perspective of looking at cancer not only as a clinical problem and as something that has a deep-rooted cultural and community impact, I think is one area that we've been lagging behind. So I think at this juncture, we have some questions in the chat box. If you'll allow me, as we wait for Dr. Kiarie, I can run through some of the questions in the chat box so that we can move on. So we have several questions in the chat box, and most of them are directed to the PS, the Honorable PS, Dr. Ouma Oluga. Again, once more, thank you for gracing this occasion. There's an anonymous attendee who wants to know why cancer should not be declared a national disaster or given the much weight, just as we saw the zeal to fight and reduce HIV. I think, Dr. Oluga, quickly, you can respond to this. Why can't we declare cancer a national disaster?
Thank you for that question. Yes.
Yes, go ahead, Dr. Oluga. Welcome back, Dr. Kiarie.
Yes, thank you. Yeah, Dr. Oluga, please go ahead.
Okay, thank you. Thank you so much, Dr. Kiarie and Dr. Iro. Well, the national disasters are declared based on certain conditions, criteria. One are things that threaten the entire population, to wipe out the entire population. And of course, given the spread of HIV at that time, it was imperative. Number two are healthcare things that threaten to collapse the healthcare system, as you saw also during COVID, where you find the healthcare system is going to be overwhelmed and then unable to cope or respond. And number three is diseases that have cross-border effects, in terms of it's unable to be contained within one. But I don't think that cancer has any of those characteristics. I know it is a challenge. It's a challenge of the healthcare system. It's a challenge of our current times, not just the healthcare system. But I believe that with efforts and with our discussions and the investments, we can do much more to increase survival. We can do a lot more to make the experiences of cancer care and cancer patients better, so that then it just becomes another diagnosis, not a diagnosis of concern as it is right now, because of because of the fact that the chances are not as high as we would expect them to be. Yeah.
So thank you, Dr. Oluga. Yes, that was a big question. Those of us in the oncology arena feel that the burden of the cancer patient and to the practitioner with the number of patients, we feel that a national disaster proclamation would lead to rolling out of resources towards this disease that we struggle to fight. But we take note of your sentiments, and probably through creating synergies and alignments like have been mentioned, Dr. Well, we can be able to get us home. Now, the other question that has been raised is by Dr. Rumesa, who is asking SHA if they can be able to negotiate bulk purchases, and what also Dr. Ogwell was alluding to about creation of supply chains of health products through economies of scale. SHA is a big payer. You pay a lot, you order a lot, and therefore they should be negotiating quantity discount from facilities. We drive 100 patients for surgery, we require 30% discount on our bills. We purchase oncology products from such and place, we require these economies of scale and quantity discounts. I know that Dr. Marion, you can make a comment to that.
Thank you, Dr. Gladwell, and thank you for the attendee who asked that question. So there are various things that we've looked into. And basically, eventually, what we want is value-based care. And value-based care means that we are going to integrate quality parameters. And these quality parameters will be defined by many factors, cost being one of them. But again, we also need to look at on the bigger picture, which was very well explained by PS Dr. Oluga. What are these bigger pillars that we are looking at? And what you need to also realize is that commodities and products is one of the areas of investments for the government in the current moment. And what we are looking is investments towards KEMSA, and we are looking at partnerships, public-private partnerships to really reduce the cost of care. Eventually, the sustainability model that we are looking at is to ensure that, number one, we can drive the agenda towards value-based care. We can drive the agenda towards integrating clinical protocols, but while looking at the inputs that are reasonably, in terms of cost of care, reasonably sustainable. So we are currently working as management on discounting policies. But key to all this is the public-private partnership. Herceptin is a very good example. And you look at the real cost of Herceptin and the current cost through negotiations, that tells you what public-private partnerships can do. Then we also look at how is it that government, through investments in products and commodities policies, will be able to control costs. So this is work in progress, and we've already made some steps towards that. And I want to actually just maybe just reassure you that yes, there are small steps, but we are headed to that direction. Thank you.
Thank you, Dr. Diana. Marion, I think with the mention of Herceptin, Prisca, I can see that you're back online and you are giving very good sentiments about the change of a single dose of Herceptin coming from 350,000 to 33,000. And maybe just to clarify that patients require up to 16 doses of Herceptin at that cost. So Prisca, we lost you, but kindly welcome back and give us your comment.
Thank you. My apologies. I experienced some internet issues. My apologies. I'm back. So I was just giving a little history of where we have come from. Then I also wanted to say in terms of timelines, we also see that approvals are quite fast. So actually it can happen the same day. But now here is the other flip side, okay? The timelines in terms of pre-authorization can be the same day if and only if the system is working. If the system is not working, then the pre-auth does not happen the same day. Currently at KNH, as we speak, from Monday, the system was not working. So which means that anybody who required treatment then was not able to get that treatment because the pre-auth could not be done. So yes, the pre-auth happens very fast, but if the system is working. Number two, in terms of the drugs we talked about, the Herceptin, from December to date, we don't have Herceptin at KNH. I want to use the example of KNH because that is where most of us go. From December to date, we don't have Herceptin. We also having challenges with letrozole. We also having challenges with Zoladex. Yes, it is good that if SHA, the systems are working, and if SHA also is paying the facilities, then the drugs are available. But right now, the drugs are not available. So you see, SHA is doing good things, but we are also experiencing other systemic changes that actually mess up the good things that SHA is supposed to do. So we need to come up with a holistic way of dealing with these things. The other thing is in terms of the facilities. For example, the longest, again, I want to use the example of KNH, radiotherapy machine is not working. Thank God we have the kind of partnership that, again, SHA has been able to enter with the private facilities like Nairobi Hospital, where SHA pays the 3,600 and then the private facility, I think they're working with Faraja, they are able not to make the difference. So which is also a good thing. So what am I saying? I'm saying that the idea behind SHA is good, but we are experiencing challenges which need to be dealt with. So we can only be able to have that financial freedom where I, as a patient, I don't have to pay from out of pocket if I'll be able to find the drugs that I require. And that we all know right now is not happening, is not what is happening on the ground, and patients need this. So we have a lot of patients dropping out of treatment. So what have I liked about SHA? I think I've basically said, but then again, I've given some conditions in terms of it can only be possible if all these other issues are addressed. Now, what are the priority issues that we are talking about? So for SHA, we need in terms of delivering a comprehensive and uninterrupted services. So which means in terms of comprehensive, number one, I talked about what we as advocates have done, and you've seen the increase from 550 to 800. But that directive was given that would be possible from the 1st of December. As we speak right now, and we have evidence from patients are still going to facilities and they are told that they have exhausted their money. And yet they know that the president gave a directive that they can go all the way to 800,000 Kenya shillings. And I like what Dr. Diana has said, that the 400 is covered by the chief, and then the 400 is covered by the ECCIF. I've learned about that right now. So that communication is not there. So that communication needs to be shared with the facilities and with the Republic of Kenya so that people can know that this 800 is broken down this way. And when that information is also given to the health facilities, then they'll be able to extend treatment to the patients once their 550 is over. So that is something that is missing. The other thing is in terms of the government equipping the facilities, again, as we try to operationalize. So the government needs to equip facilities, like for example, KNH, I've given the example of the radiotherapy machines. I've also talked about the issues to do with the drugs. So if the government can support these public facilities to have all the correct infrastructure, then now the people can gladly enjoy the services from SHA because they'll be able to find them. But then when they go here and they cannot get what they want, then you still go back to the same issue of having mental issues as a cancer patient, worrying not only about your treatment, but about where are you going to get the money, because if the SHA is not working for you and you go to a private facility, then you have to go into your pocket. If you don't have the money, then you abandon your treatment. The other thing that I would also like to talk about is in terms of timely reimbursements to the facilities. Again, as KENCO, we have engaged with the facilities, and I'm not going to name them because of privacy issues. They tell us not to. Some of these facilities, they have been complaining about the issue of timely payment by SHA. So what do? They deny the patient's treatment. So when the patients again are denied treatment, what happens? They are referred to the private facility. Again, the whole cycle comes back. They are referred to the private facility where they are supposed to, to use their out-of-pocket, which they don't have in the first place. So again, we go back to the issue of this cancer patient going through a lot of stress, both mentally, emotionally, and even physically because of the disease that this patient is going through. So for me, I'm talking about operationalizing and ensuring there is uninterrupted cancer care service, which can only be done if all these institutions that are represented here are able to work together and to ensure that we have a working health system. The other priority area for me is in terms of financial protection and support to survivors. So when you look at survivors beyond the disease, there are issues to do with mental issues to do with nutrition, issues to do with rehabilitation, many issues that are not really covered by SHA. We need to see SHA having a comprehensive package where they are able to take care of this. I want to go as a person who had breast cancer and I've had a mastectomy. I want to be able to buy a breast prosthesis using my SHA. I want SHA to be able to take care of that. So yes, I know SHA covers some of these assistive devices, but it doesn't cover some of these that we need, especially like breast cancer patients who need breast forms, but they're not able to afford them because they are very expensive. So if SHA is able to take care of the psychological issues, the nutrition, and the rehabilitation. The other thing within improving the financial protection and supportive care for cancer survivors for me is it possible, and this is something I was just thinking about, that we have the chief coordinated with social protection. Within this country, we have Inua Jamii. We have, old people are given something when they reach a certain age. Is it possible that when a patient is going through treatment, and majority of these patients do not have jobs, when they are going through treatment, they can be given something as social protection so that these can be able to take care of them. Even as SHA takes care of their treatment, then they also have now that social protection where they're given something small and they can use that for their food, because they need to eat, and for their other things that they need to do. So those two things for me, ensuring that we are operationalizing SHA, we are not having interrupted services, and these directive by the president, we are able to see it actually happening, because like I said earlier, I do have evidence it is not working. It is a good thing and we really welcome it, but it needs to work. And they can, all the organizations represented here, work together, because that is all we need. And I can tell you, history will judge us so badly many years later when we were not able to help vulnerable patients that we would have been able to help had we done something today. So I think we are having this conversation for you to be able to hear what is happening on the ground. And then we sit and discuss and see what can we be able to do to make things better, because nobody wants to throw stones at anybody. We just want to improve our health system. We want to make sure that we are helping this vulnerable patient. Let not history judge us for not looking at the vulnerable cancer patients. Thank you.
Thank you. Thank you, Prisca. Spoken with great passion, and you brought out a few things that are very, very important. Cancer care must be continuous, it must be consistent, it must be well coordinated, and most of all, compassionate. I just want to go back to Dr. Ogwell because of one of the questions from Nicodemus, who says he talks about SHA providing palliation, pain control, and probably counseling. But I want to go back to village reach. And also, loop in Prisca in this. In what help can survivors, can organizations with community outreach be able to offer this support? Probably even extend the help that Prisca talks about to reach the person in the village, offering them support, this counseling, shared, some of these cancer groups to be able to have sort of a village outreach. Dr. Ogwell, how can you partner? I think, we should ask ourselves how we should also chip in and be able to help in small fragments and be able to coordinate this care. Would an organization like Village Reach be able to step up, offer counseling, palliation? What can you do with us, Dr. Ogwell?
No, thanks for the question. So I think that there are two important parts to this. One is locally organizing, and I think Prisca is here as part representing the coalition, locally organizing to be able to address issues around cancer all the way from the beginning in prevention and towards the very end, palliation and everything in between. So getting locally organized is an important part of that. Then the second is being supported to be able to do the work. And this is critical. And I would like to first start by asking Shah, Dana, the focus is a lot on the clinical side, but I think to address issues of reducing the burden of people coming to the hospital, the preventive side also will be a very good area for SHA to invest in. But to the question about village reach and what we can be able to do, we will need to see the specifics of what the organization that is being referred to is doing and how it is engaging with the communities. Because for us, what is important is that communities have the right information and can therefore be able to make decisions about their own health within their own context and become and avoid disease and different conditions that are going to deplete their health. So if there is an organized way that the groups have already organized themselves in a way that they can be able to deliver some service information to the communities, then this is something that we will be happy to look at and consider. But for sustainability, I think a portion of SHA resources should go into community engagement, which gives primary prevention, secondary prevention, and also contributes to health promotion in a way that reduces the number of people who end up consuming clinical care and therefore the budget of SHA. Thank you.
Thank you, Dr. Ogwell. We ask that question in the realization is, what else can we also do to help ourselves? I think as we are waiting for Dr. Nyikal to come back on, I'd like sorry, Dr. Oluga, you're going to take the brunt of probably what we would have asked Mheshimiwa Nyikal. There was an article in the Lancet Global Health that alluded to about 1 in 6 of all oncology products being unfit for consumption by patients based on their appearance, on packaging and labeling. There was a study carried out led by a professor from the Notre Dame University in Ethiopia, Kenya, Malawi and Cameroon, where they took 251 samples of oncology products and found 1 in 6 to be unfit. And they also found the active drug component to be minimal. Just a question to you, Dr. Oluga, about what the Ministry of Health should do in probably ascertaining quality of some of the products. We're talking about access, we're talking about patients getting treatment, but is it quality? Is it safe for consumption? And in the same vein, what can SHA do to that level? Dr. Oluga, thank you. We're still hoping Dr. Nyikal will join, will come back online. Thank you.
Dr. Kia, you wanted me to mention about quality?
Yes, about, we are talking about access of all these products, and I alluded to an article that was published in the Lancet Global Health magazine that talked about 1 in 6 of oncology products being unfit for consumption. It's a big burden to government. We're talking about provision of care. We're talking about diagnostics, but who is inspector of quality?
Yeah, that's quite, quality is a discussion that will go on for quite some time. But I think for us, the way we look at quality are two things. One is the products competent, and competency, I think that's what we call efficacious in terms of, are they solving the problem that they are meant to solve? And number 2 is, are they safe? And so I think from that perspective, it's very important that we have a regulatory system that is strong. Our regulatory system right now, we are gearing towards what we're calling maturity level 3, where we are having key corrective measures to ensure that the products that are coming in have gone through some level of verification for this quality testing. Of course, it's still a long way to go. As you know, that drug testing is in itself requires a lot of investment. And so sometimes there's a lot of reliance on institutions or countries that have robust systems. But that's where we are going. Recently, we signed our US government Kenya cooperation framework. And one of the things that we are looking at is to adoption of what we are calling GS1 standards. And that's one mechanism of trying to ensure that our products are quality. But I think from a patient perspective, or from the service point, the point of care perspective, for us, it's about, has the product or has the drug done its work? That is the patient getting better? And number 2, is the patient getting better and the medicine is safe? It's not causing other problems other than beyond what it was supposed to cure or to correct. And then I think from that simplistic perspective, we are also looking at doing a quality of care, which the quality of care is more about the services. It's more about the service quality, and that's where I've been very keen on how we do integrated care. I know that talking about oncology and cancer, there is, of course, need to strengthen intercadre or interprofessional collaboration. I have had our colleague from KENCO talking about nutrition and all of that. And sometimes, you find many of our patients, they're undergoing chemotherapy, but the albumin levels are quite low. And so there's a lot of effects around some of these things. So the quality of care is also about the service, how we integrate our professional collaboration to ensure that the patient gets the best from all of us, not just the best from the ultimate specialist. And that's something that we have done a bill to Parliament. Again, Dr. Nyikal may speak to this, and we are hoping that this will be the 5th piece of legislation alongside the Social Health Insurance Act, the Primary Healthcare Act, the Facility Improvement Financing Act, and also the Digital Health Act, so that we tie the healthcare system with some basic framework for establishing a mechanism that assures all our patients, whether cancer or otherwise, of quality. But the last piece about quality is about the healthcare system itself. And sometimes quality is also cultural. And, when you talk about places where people have a certain way of life, and I think that's something that we have to improve within our healthcare system. There are some habits that we have encouraged for so long that we now need to drop. I have had, engagements, of course, with healthcare workers in just the design of our healthcare system, but also some practices that we have that sometimes don't assure our patients of quality. And from a Ministry of Health perspective, we have noted some of those, and we are keen to work with stakeholders to correct them, part of which is just the amount of time we give to our patients. And that amount of time translates to what we call concentration of the clinician or the physician on that case. And I know that some of this we are going on the side of SHA to talk about, we want our health workers to have a primary place of practice and a secondary place of practice. And because we're just looking at how much can one person divide themselves, even if you are the most knowledgeable. But of course, also there are several models of care now, of course, with technology and with the centers that we have, the hub spokes, where maybe you design treatment protocols, but then the delivery of that treatment protocols then requires translation, requires training, and requires a delivery model that may be separate from the person who actually designed or who developed the treatment protocol. So all of these things are key for us to improve the quality of care for our patients. But all in all, I think quality becomes an ongoing discussion. We have a piece of legislation that is awaited. We continue to improve, including even the quality of diagnostics, the quality of the CT scan. Many of the things that Dr. Gladwell, you mentioned is, 2 weeks for confirmation of diagnostics. But in our healthcare system, for example, many times we have a CT scan that has to be repeated because the first one wasn't properly done. And those are quality issues, but sometimes they come out as financing issues from on the Social Health Authority side or on the insurance side, but they are quality issues. And I think it's something that also we have to really put our minds to, because ultimately it is you, the professionals, who have to solve this problem. And you have to solve this problem by coming up with adoptable solutions that then we can embrace as the Ministry of Health and then entrench, whether as a policy or as a standard. And the last thing I want to say here is that there is no shortage of quality standards all over the world. And I don't think that we should struggle so much to reinvent the wheel to figure out what needs to be done. If you go to many places, they adopt this quality from this place and this other quality standard. And I think we need to figure out what works for us, and we iterate, we apply them, we see where the gaps are. But operating in a system without some level of standard, I think is not the best practice that we want to have. Thank you.
So, yes, thank you very much. That was quite elaborate, Honorable PS, and we've come up with quite a bit of discussions and the balance. I think we were alluding to pharmacovigilance, and I think the things that you talked about, including digitization, where we can have sort of mobile phone reporting about quality of drugs, will also be a very big help. I think.
Sorry, there's something important that I needed to speak to, what we call the the pharmaceutical package, which we are also developing, and really to address specifically what you've mentioned about the quality of the products that we deploy and dispense to our patients. And I think that responds to the need to what we call post-market surveillance or pharmacovigilance, and also it responds to some of the things that we need to do to ensure that we continuously avail products that have been tested and products that we can trace to their origin and know whether we discontinue or we continue with them depending on the quality outcomes. Yeah, thank you.
Thank you, Dr. Oluga. You've been extremely, clear in what you have presented, and I think that creates a lot of hope for many of the people listening in this platform that we can create synergies with some of the key players. I'll just ask Dr. Oyiro if we've been able to get back to Dr. Nyikal. We were very, very keen in hearing his comments, especially about, provision and access of oncology care. I had alluded to the example of Kenyatta University Teaching, Referral and Research Hospital. The current state it's in, because, there's a big SHA bill pending to be paid to Kenyatta University. And recently, even lack of provision of even blood transfusion material. And this was a center that is very pivotal in provision of care, because a lot of investment in radiotherapy, in chemotherapy, in very good services has been made in that center. And Dr. Nyikal, as you recall, the parliamentary committee, probably two before you, actually gave a 3 billion bailout to Kenyatta University. What is a parliament doing to be able to improve this? And I'll also welcome your comments about SHA. We've missed you in the long discussion, but I'm very sure you've been listening in and you can give us your 2 cents on some of the things we discussed about health financing. Thank you, Dr. Nyikal.
Well, thank you very much. It's unfortunate that I really couldn't participate in. I still try and get a laptop, which didn't work either. Now, basically, the approach that I see, starting first with your question of what can Parliament do, is one Parliament, of course, it's legislation, there's oversight, and there's also budgeting. So in terms of legislation, of course, there are laws and bills that Honorable Luga was talking about. Some directly relating to cancer and some to healthcare in general, like the Cancer Institute that we have. That was a law that was passed in Parliament. I think in even an amendment trying to put emphasis on training of oncologists and provision of services. So Parliament is key in actually giving the legal framework. The other area that Parliament is important is actually in budgeting. And as you said, Kenyatta was bailed out. But even at the very beginning, and when the university hospital, when it was supposed to be a university hospital, when it started, Parliament had to actually give the money to actually start it running. So funding is extremely important, Parliament. So there is legislation, there is funding, and there is also oversight. Now, oversight is actually when we work with the ministry and to some extent county governments to see whether what is said to be done is being done. Now, in my view, when I look at cancer in this country, we have actually found ourselves in a situation that we have actually anticipated. Actually, we did anticipate it. Remember, when I was the Director of Medical Services, we were putting a lot of emphasis on how can we get preventable cancer prevented, like cervical cancer, and early diagnosis. When we were doing things like visual examination, when we were putting a lot of emphasis on things like mammography and physical examination. And so early diagnosis and prevention, like in few cases like cervical cancer, is key. If we're going to have a program, let's think what we can prevent. Can we? In my view, for example, we should actually have a program which is indicating that in another 20 years from now, we should actually be having cancer of the cervix as a clinical problem, because we have the vaccine is available. Cost of course is an issue, and that's where Parliament can come in. Then we also should look at early diagnosis. Again, if you do early diagnosis in the treatment, is much cheaper. So in my view, we need a program that is looking at that area of health promotion, prevention where possible, early diagnosis for all cases. So we should have screening program for breast cancer, for cervical cancer, for cancer of the gut, like cancer of the colon, prostate. These are areas where we should put a lot of emphasis on screening and early detection. But now where we find ourselves, we actually have gone in treatment area, and we have gone extremely expensive areas in treatment. Like if you're talking about chemotherapy, I think it has the state-of-the-art treatment in all areas. And again, that is so expensive that we probably are not able to afford it. That is why we're now having this, like what you have mentioned, even simple things like blood transfusion, because late stage of cancer is actually expensive, and even the returns are not that good. So mine, Dr. Oluga is there. We need a double program. One, looking at early detection, prevention where possible. Two, now how do we improve the treatment for people who are sick? And that is where actually the problem is. And if you're not careful, we are actually going to spend a lot more money in the treatment at this high level, because it is demanded. It's demanded. What the issue, like we had in Kenyatta yesterday when the PS was there, those are very serious demands that the system will actually tend to respond to, and then probably lay less emphasis on prevention where possible and early detection. Me, I would put those basic issues. How do we balance the two? Now, when we come to treatment, now we are actually trying to put cancer centers. Look, I will tell you, we have one in the university, that's a hospital, Eldoret. We have a thing the Coast General. We are trying to actually they're trying to put up one in Kisumu, and they are removing so these centers will also require a very serious referral system. And the drugs that we use, some of them are very expensive. So are we able to really afford it? Now comes in our financing system, and we are talking of SHA. SHA is actually something that can really get us out, but I think we have rather long-lasting teething problems, as Dr. there would know. And if you talk even of the benefit package that we have, maybe as a country there's something we have also not done. We have not done cost of care. So we have designed a benefit package, but the benefit package must actually be in line with the cost of care, so that what is paid by SHA actually covers the cost. That is why when we had cancer, when we started the package that was giving, I think, 450,000, we quickly discovered that that is not adequate. Okay, now we are going to do it. I'm quite sure that when the system, when it really picks up well, even that will not be adequate. We have the four funds. We have the SHIP, the primary care fund, we have the emergency and chronic care fund. Now, again, even those ones, we may still find that it won't come. So it's something we are trying. I'm happy that we are both looking at the prevention, promotion, early detection level. But there's we have been pulled a lot if you look at it to the more expensive areas because the people are already there and there. And I actually do appreciate from where I sit, the health committee, that there is some effort that is being done. We are going to try and put more funding in this as possible. And when we come funding, then we look at SHA. SHA now, the big question, Dr. Oluga, is there is, first of all, just the system. The problem we have in Kenyatta is just downtime. For the time when things are not working, downtime when the system does not work, and therefore patients wait for long. We also have a sense of approval, which also takes a bit of time. Then even when treatment has been given, now again, paying the facility is an issue. We are talking about what SHA owes. That's it. So these are things that we need to look at. We have a bit of everything in place, but we have not really been able, and this is what we're probably working with, Dr. Rivera and my committee, to put a framework that puts everything in place so that when you're treating people, if you look at our benefit package now, it doesn't even take into consideration like diagnostics. We may say, okay, this drug is available, but when somebody goes for treatment for cancer treatment, look at the diagnosis, the supportive diagnostic, for example. Those are extremely expensive, and the follow-up that is required, the support like blood transfusion. So again, we are in an area where in my view, I would just summarize and say, we are going to have to look at the two arms together. How do we reduce the disease burden? And then how do we take care of the disease burden that is already being done? So as a country, that is the balance. As parliament, where the laws are required, I think we can put people that in place, whether it's policies, whether it's actual laws, can put that in place, whether it is the quality of care, like we have the quality of care base that is coming, we can put those in place. But a broader picture, I think is what we need, a broader framework, and then we can improve bit by bit. But how do we try to reduce the burden so that then the money we have can actually give our people the care that we need?
Thank you.
I missed out a lot, but I think that's what the summary can give.
Thank you, Honorable Dr. Nyikal. That issue of legislation, budgeting oversight, and I think with the SHA representative, Dr. Diane has told us, I hope that the two will meet at least halfway to be able to finance some of these programs that we are talking about. So we've carried on with time. Our CMEs usually end in 1.5 hours, but we've had very interactive, interesting discussions. Some of the players we've discussed with, Dr. Ogwell will be reaching out to you to do some of our outreaches with KESHO, and it has been a very informative meeting. I've tried to integrate some of the questions in the Q&A from various places, and some of the questions are repeated, and I've tried to put them forth. We remain with a lot of work to be done. I think to us doctors, aligning protocols, creating timelines for early diagnosis so that we can also be able to control costs and come up with evidence-based management so that there is no inequity in what we give a patient in Turkana and what we offer a patient in Nairobi. And also we've learned about incorporating digital methods to be able to hasten some of these diagnostic processes, use of telemedicine to have MDTs, and etc. So Dr. Ogwell talked about moving the diagnosis, not moving the patient. That is indeed quite important. He's talked about community navigation, and that's where we should be able to align and cooperate and partner. And we do appreciate you, Dr. Diana, in the information you've given us about SHA. There's still a lot to be done, but we do appreciate a lot has been done. I think the take home is government cannot do everything. We'll basically have to accept the copy method and be able to look for other strategies, people in NGOs to be able to also to chip in as much as President Trump is trying to reduce this, probably see where we can create synergies to help our people. Creation of quality parameters. We've talked about pharmacovigilance and, also talked a lot about all the other things we can do to help our cancer patient. I think at this particular moment is to give a great thank you to all the panelists. KESHO will put together the discussions that have been had, and we'll be reaching out to each of you to be able to continue this conversation. I think I'll invite Dr. Peter Oyiro, who is one of the executive members of KESHO, to be able to give us a vote of thanks and a goodbye for such a wonderful continuous medical education session. Thank you very much. Karibu, Dr. Oyiro.
Thank you very much, Dr. Kiarie, for such an elaborate moderation of this very important session. I think time is well spent. I just like to thank our guests, starting with the Honorable Dr. Ouma Oluga. And the PS, we want to promise you that, discussion about cancer care and SHA is for all of us. I think we need to stop looking at SHA as belonging to other people, and us, we are on the other side, poking holes and highlighting the failures and forgetting to see the milestones that we have had so far, as has been enumerated by majority of us who have spoken this evening. Dr. Nyikal, Honorable Nyikal, I think you've elaborated very well the role of the legislature in cancer care and in healthcare in general. We thank you for gracing this occasion. We've learned a lot, and we have been very encouraged that you are going to look at the health budget. According to the Abuja Declaration of 2001, 15% of the total country's budget should usually go to health. So while budgeting and agitating for more funds for health, put that in mind. Dr. Ogwell, your multi-sectoral approach to cancer care and community engagement, I think is the highlight of your presentation this evening. We seem to sometimes get out of touch with the community, and thank you for bringing this very clearly. And Marion, I think the issues of SHA has been clearly, highlighted by you. We thank you for coming. There are many questions about SHA, and as I always say, that SHA is there to support the basic. I think we are in a developing world, so we would really want to do many things, from diagnosis, cosmetics, and all that. And I think SHA stands a better chance to move us to, universal healthcare. Prisca has passionately talked about, advocacy and lived experiences. Thank you very much, Prisca. I think you've spoken today to the right people. The Honorable Ouma Oluga, as I know him, is a man who acts. He has listened to you, and I think you represent the many patients, and you have enumerated very well the journey that patients go through in a bid
Dr. Ira, this honorable thing,
yes,
where
sir.
did it come from?
Okay, noted, sir. Noted, sir. You're honorable to us, being in the
No, I
union
am just,
and being
honorable
the...
in this country. You okay.
But well guided, sir. Thank you for joining, and to our attendees, thank you for gracing the occasion. We hit 600 at the peak, and I'm glad to report that majority of us stayed on up to now. It is 6 minutes to 9, and we thank you very much for listening. We apologize for not having enough time to respond to your questions, but we'll compile them and reach out and provide some of the responses to those questions. To the KESHO Secretariat, thank you for setting this up. The World Cancer Day has been well concluded. It is usually a day to educate the people and really showcase people-centeredness. And I think KESHO stands in a very vantage position to push this people-centered cancer care in Kenya. And with those few remarks, Dr. Kiarie, if you may allow me, we can close this session and wish everybody a good night. Thank you very much.
Thank you very much. Good night, everybody.